So, hello everyone. Here is number to set with a disease that affects roughly 1 in 10 women, and that on an average takes 7 to 8 years to diagnose. In that time, she might see huge number of doctors, one after other. Her pain is normalized as a bad periods or mislabeled as irritable bowel syndrome, or years and years will go on, and that disease is endometriosis. And in next hour or so, I want to change the way you diagnose it, or rather than have some emphasis how we approach the endometriosis. Welcome to Horizon Masterclass episode 1. I am Dr. Priyadatt Patel, your gynecologist, laparoscopy surgeon and fertility expert, and this is our episode 1. We will examine endometriosis in adult through one deliberate lens: how it presents, how we evaluate it, and how we actually reach to a diagnosis. Treatment we will leave for a later episodes. Kind of, if you are, so I personally hope that this will help you out and clear few of your doubts in your day-to-day practice. So we are going through very advanced gynecology and fertility in this Horizon episode series, one by one at a time, one topic at a time. And because there is lot of concerns, the disease of delayed diagnosis, low clinical suspicions, and the diagnostic pathway is not kind of black and white. It's a single highest yield thing which we can control for better outcome or well-being of a patient or a person or a female as far as endometriosis is concerned. A word on positioning: I speak as a gynecologist, reproductive medicine and advanced laparoscopy surgeon, and that interpretive frame I will apply it explicitly, prioritizing the long-term outcome over aggressive intervention, protect ovarian reserve, and kind of graded recommendations by evidence quality rather than assertion. And where the evidence is strong, I will say so, and where it rests on expert opinion and or a single study, I will label it as such. For a transparency, the content is not of what I have generated, but through lot of evidence and guidelines, reviews by lot of our colleague and studies, and the current literature till date may be mid 2026. Cross reference to a major society guidelines, particularly ESHRE ACOG Clinical Practice Guideline number 11 2026 and NICE Guideline 24. So I will attach evidence categories with this kind of presentation, and we will only discuss with the verified guideline, emerging and controversial concepts. No reference or statistic in this slide is fabricated or kind of my home or my personal opinion, but yes, we generally follow this on our day-to-day practice. So the learning objective mainly is to characterize the symptom spectrum correlated with the lesion phenotype and account for diagnostic delay and its remediation, conduct a structured evaluation, interpret transvaginal ultrasonography and MRI finding including their operating characteristics, limits, and select rationally between presumptive clinical and surgical diagnosis, and apply certain classification, mainly revised ASRM classification, Enzian classification, AAGL classification, EFI, that is Endometriosis Fertility Index system, and construct a system-based differentials for chronic pelvic pain. So basically this presentation is having 8 layer structurally educational dependency rather than source order. So foundation biology proceeds mechanism proceeds clinical decision. The two concept pivots I would flag in advance are the imaging section and presumptive versus surgical diagnosis decision. The remainder of the argument coverage on those 2 points. So as you can see, disease concept and distribution, epidemiology, natural history, clinical features, symptomatology, why diagnostic delay, evaluation, that is history and examination, laboratory and what are the biomarkers, imaging, that is ultrasound and MRI, strategy related to the diagnosis and also the surgical diagnosis whether it's required, classification and staging of the disease, its importance, differential diagnosis, and decision intelligence along with the integration of available evidence. What are the latest guidelines which we tend to follow? So first is disease concept in anatomical distribution. So let us begin with the disease concepts in its anatomical distribution. So endometriosis, very important. What we generally say is ectopic implantation of endometrial cells or endometrial like glands and stroma. One precise thing you have to understand. Endometriosis is presence of endometrial like glands and stroma outside the uterine cavity. Here the like word is very important. You can see why the qualifier of endometrial like is deliberate. This is a ectopic tissue. It is molecularly and functionally distinct from the eutopic endometrium, the normal endometrium which goes outside the uterus. Their molecular and functional capacity is distinct. That's why it is called as endometrial like gland and stroma, which is why it behaves as a estrogen dependent chronic inflammatory disease rather than a simple displaced lining. It manifests across the premenarchal, reproductive postmenopausal phase, and it is the ectopic tissue together with the inflammatory response that is the production of symptoms, mainly dysmenorrhea, dyspareunia, chronic pelvic pain and infertility. Very important. Ectopic tissue together with the inflammatory response. So disease and body reaction both takes part. So both the image, different characteristics. Take a moment with this comparison. On the left the normal pelvis, on the right the same anatomy studied with the endometrial implants, endometrial like glands and stroma outside the uterus, driving the inflammation, pain and fertility issues. The disease is a kind of very complex. It is difficult to describe in one words. So where endometriosis occurs, its distribution. So anatomically, disease is typically confined to the pelvis and ovaries, pelvic peritoneum, uterosacral ligament and pouch of Douglas. The rectovaginal septum, bladder and ureter, they are, yes, in certain cases may be affected, but it is documented that extrapelvic site, mainly upper bowel, abdominal wall, surgical scars, the diaphragm, the pleura and the lung are also there, which can be affected by endometriosis. Clinical corollary, which is kind of I developed throughout, is that anatomical site determine the presentation of the disease or presenting symptoms. Appropriate imaging modality is also dependent on that, and the surgical team which is required will also dependent on that, whether the extra pelvic and deep disease mandate multidisciplinary approach or not. Because why it matters? It is a site distinct specific primary presentation of the symptom, again imaging choice, again surgical team, and again multidisciplinary approach. So this is a revise the same thing. Here is the anatomical distribution laid out, kind of disease cluster in the pelvis, ovaries, uterosacral ligament, pouch of Douglas, rectovaginal septum, bladder, and bowel. Sometimes it reaches to a diaphragm, abdominal wall, thorax. So every site on this map produces its own characteristic kind of symptom signature, which is very important. You can see ovaries, endometriosis, chocolate cyst, fallopian tube, uterosacral ligament, each have a specific intent, right? You can see based, some are common sites, some are kind of frequent sites, some are less common sites, and some are possible rare. So common question sometimes patient ask in OPD is, sir, if I have been affected with the endometriosis, what is my phenotype? Or there is a three major phenotypic presentation of the endometriosis. Contemporary practice is recognizing these three lesion phenotypes, and ESHRE structures its recommendation around them. That's why to understand these phenotypes are very important. Superficial peritoneal disease, they are mainly flat implants. The phenotype imaging most often fail to detect because in sometimes or majority of the cases is a presumptive diagnosis. The ovarian endometrium or chocolate cyst with its characteristic ground glass morphology on ultrasound and deep infiltrating endometriosis defined as lesion penetrating more than 5 mm or more beneath the peritoneal surface. Lesion penetrating 5 mm or more beneath the peritoneal surface, which accounts for most deep pain or operative difficulties or complexity of the disease. This evidence indicates phenotypes rather than stage because they are not mainly correlated. You have to understand, right? So best practice predicts the symptom profile and the phenotype frequently maybe coexist with each other. So there might be some kind of overlapping. So yes, in a nutshell, superficial peritoneal implants or endometriosis, which is called as peritoneal disease, then ovarian disease, endometrioma or chocolate cyst, and third is deep infiltrating endometriosis or a deep disease, right? So few of the examples are there. Sometimes they are overlapped, so you have to understand. So three phenotypes side by side: superficial ovarian and deep disease. Again, the laparoscopy appearance you can see below few of the examples, because to identification of this disease in laparoscopy is always not straightforward, because identification is the key thing for excision and they are more important than the stage to predict the patient, how the patient have a severity of the symptoms. So to consolidate disease definition, that is ectopic endometrial like gland and stroma, localize it, pelvic, extrapelvic, phenotype it, site specific symptoms, more kind of we put an emphasis rather than histopathological stage, correlation with the clinical presentation and pre-operative planning. So these are the four things we have reached till date. Now the section second, that is epidemiology and natural history. So why turn to epidemiology and natural history? Very important, very important. Key question is who gets it? So rather than why certain people only getting it, when they are going to get, and does it inevitably progress? Key, very key, mainly focus age distribution, progression and regression. So age distribution, so in a kind of common language it is called as reproductive age disease. Peak prevalence lies between 25 to 35 years. The clinical importance qualification is that the age distribution is wider than commonly taught. Premenarchal disease, yes, I have seen personally, we have operated, it is reported, including the absence of obstructive anomaly, because in obstructive anomaly it is very common. In postmenopausal, yes, we have operated the patients, in postmenopausal endometriosis. So therefore, age has no kind of black and white or clear cut boundary, has no discriminatory value for exclusion, but yes, they are mainly seen along with hormonally active female or kind of reproductive lifespan. Next common question is, does endometriosis inevitably progress? Is the disease progressive? The natural history and data argue against a uniform view. So kind of we sometimes very aggressively say to the patient that disease is always going to progress. Believe me, there are a lot of data on the studies available, which we also come to know on repeated studies or repeated kind of guidelines follow up, that natural history of the data argue against a uniform view that disease of the endometriosis inevitably progress. In a second look laparoscopy studies for untreated women, disease progress in roughly 29 to 45% of female, right? Regresses in 22 to 29% and remains stable in 33 to 42% of patients. So in a prospective cohort of 88 women with rectovaginal disease follow-up 1 to 9 years, fewer than 10% progress is very important. So that's why in recent time we went from very aggressive endometriosis excision of the bowel nodule to a kind of conservative excision with shaving technique or kind of partially shaving technique for as patient to reduce the morbidity of the patient and improve the fertility outcome, right? So the trajectory is heterogeneous and the evidence directly undermines any reflective rationale of operating early merely to prevent the progression. So you have to identify what are the patients who require intervention and what are the patients you can put for observation. Again, for that also no clear cut boundary, but yes, you can go step by step. So again, to summarize, 88 patients on follow-up rectovaginal disease 1 to 9 years, 29 to 45 progresses, 33 to 42 remains stable, and 22 to 29 has regressed, right? So don't take it as a uniform statement. I'm just kind of giving you an insight that whatever our kind of cultural or academic cultural belief that endometriosis always progresses is not like that. So thorough counseling of the patient and balanced surgical intervention is very important. So intellectual honesty requires stating the gap. The determinants of progression versus regression are not known, because these that is what I was saying, this thing is kind of gray matter. It's not completely black and white which patient the disease will regress, which patient the disease will progress, and that is the only problem we have faced till date, and that is what nowadays our target is as far as endometriosis is concerned. So change in the lesion burden correlates poorly with the change in symptoms. That is another issues we have found out. Prognostic counseling must therefore be individualized, probabilistic, not kind of deterministic. An important point when kind of you consider a patient for intervention. So very important. So clinical features and symptomatology, the key question is, how does endometriosis actually present? Most important thing, the classic triad of presentation: pelvic pain, infertility, ovarian mass. Classic reproductive age presentation is a triad: pelvic pain, infertility and ovarian mass. Yesterday only we have discharged one patient, 24 years, severe pain, previous 7 to 8 MRIs, 3 CT scan. Even I have sent a patient for MRI to a center where we routinely sending a patient, and they initially also thought that there is nothing inside the pelvis, everything is normal, ovaries are completely fine, uterus is completely fine. In sonography I could make out there is a 3 by 4 centimeter retrocervical nodule. On second MRI, along with cervical and rectal gel, they could identify the parametrial involvement along with huge retrocervical nodule. The presentation of patient is severe symptoms during periods. She has to take a injectable analgesics. The problem with that is ovaries are normal. So just to presume that patient will have endometriosis, it is so difficult for us even to kind of counsel to the patient and their relatives, and the relative feels that patient is lying. But it's not always so. When there is a repeated symptoms, increase in severity or very high severity, you have to understand that there might be something inside and you have to look for it again. And we also miss sometimes, it's not like that, but we ask the patient to come for a follow-up and we'll see a presumptive signs and then we'll go on from that. So classical reproductive age presentation is yes, triad, pelvic pain, infertility and ovarian mass, but it's always not so. Single symptom presentation may predominate. The literature is consistent that symptom severity does not correlate with the disease extent. The dissociation between symptom and anatomical burden is recurring theme rather than recurring presentation, and has a distinct implication of for staging. We will discuss this in very detail in later date or kind of later slides, but yes. So this is a classic presentation. Symptom, whole spectrum, which raise the suspicion, because suspicious is the key to for early diagnosis. The symptom that should raise suspicious is progressive dysmenorrhea, very important, chronic pelvic pain, deep dyspareunia, dysphagia or dysuria, very important, infertility and other systemic symptoms, right? Fatigue, bloating, nausea, uneasiness, weakness. When several of these clusters are present, your index of suspicion should rise sharply. Because endometriosis is a clinical diagnosis. You need to be very kind of suspicious, because it's always not like you will get the clear picture. Okay, patient has a chocolate cyst and tumor and bowel nodules and kind of severe adenomyosis. Core symptom set comprise of chronic pelvic pain, variable dull, throbbing, sharp, burning, either cyclical or a non-cyclical pain, severe, often progressive dysmenorrhea, dyspareunia characteristically deep dyspareunia, not at the level of introitus, abnormal or heavy menstrual bleeding, and fertility issues, that is infertility. Additional and frequently kind of under recognizable features, sometimes when you found out the symptoms of endometriosis and found evidence on sonography, you have to be direct to ask this question whether any bowel or bladder dysfunctions are there, low back pain or chronic fatigues are there or not. Very important, more the merrier. More are the symptoms, higher likelihood that patient may have endometriosis, but it's not always diagnostic, so you not be strict to it. On symptom burden, the case control evidence is instructive. In a cohort of more than 600 affected women, 20% reported 5 to 7 symptoms. Against only 2% of reference women, the 7 visceral symptoms include non-menstrual abdominal pain, that is pain not related to period, dysuria, dysphagia, kind of altered bowel habit, irregular bleeding, nausea and fatigue. However, some literature is explicit that symptom constellation cannot in isolation confirm or exclude the diagnosis, so it is for suspicious purpose. They modify pre-test probability and should trigger the evaluation, not substitute for the final diagnosis. So again, increasing number of symptoms raise the probability of endometriosis, but the symptom constellation cannot by themselves confirm or exclude the disease. Use them to raise suspicion and trigger the evaluation, not as the diagnostic test. Endometriosis can be sometimes symptomless or a silent. A meaningful proportion of endometriosis are mainly in incidental finding. In our routine OPD, we sometimes see a patient for preconceptional counseling and turned out to be found having a severe endometriosis of frozen pelvis. Endometriosis may be, kind of detected incidentally at sometimes, diagnostic laparoscopy where grade 1 disease can be identified. It's another issues altogether. So detailed history is very important. Absence of symptoms does not exclude the disease, and this asymmetry constraint purely based on symptom rule is not diagnostic. So you have to understand that this you have to keep kind of suspicious based on symptomatology of the patient. This is very important, deep dyspareunia. Why we are discussing it? You have to understand the difference between dyspareunia, which is deep versus superficial. So proximal dyspareunia or localizing the pain has a genuine diagnostic value. Very important. Proximal or a deep dyspareunia implicates peritoneal and deeply infiltrating lesion over the uterosacral and cardinal ligament, pouch of Douglas, posterior fornix, and anterior rectal wall. Distal or a superficial dyspareunia, instead of reflecting the deep nature, they reflect at the introital lesions, cervical lesions, hymenal issues, perineal issues, episiotomy scars. So deep dyspareunia should therefore prompt the deliberate protocol imaging of posterior compartment, mainly vaginal or rectal gel, may require when patient is suffering from deep dyspareunia.